if those networks were part of an age-friendly ecosystem or system of care, then they are the engine of integrated care. They are the people who see people, who know their circumstances, who understand their social circumstances, who may know that there is no food in the fridge, as Cathal was saying, on a routine basis. So there's nobody better placed than the primary care team and GPs to be the drivers or a substantial contributor to an age-friendly system. And the other person that you might have in the chair is really the citizen, the person, the resident, the patient, because the most challenging aspect of this is really not the technical aspects. You know, we're all knowledgeable enough to be able to address mobility, medication, and mental health, but the what matters piece is a really challenging piece. And so, you know, part of what's been adopted now in the language of some of the residents that engage with this as part of committees in our residential care facilities is to be saying, well, actually what matters to me is, you know, not to have the extra medication, or to be able to get up at 10:30 in the morning, or I want to be able to go down to the local men's shed. Or in the case of Charleville, I want the footpaths fixed outside our nursing home because I'd be able to walk down to town and have a pint. And the Age Friendly Ireland with the local authority actually are repairing the footsteps in the last few weeks, so or the footpaths. So, you know, I think the person, the citizen, driving what matters to them, as per Kirsty's last example, and certainly primary care.
Oh, absolutely. No, thank you for that. And Cathal, coming back to you and looking at the journey you've been on with the National Ambulance Service, I was struck, and actually was the theme in a number of the talks about on the education side of things. My sense over the years is that we educate in silos, we train in silos, and yet we expect everybody to work seamlessly in teams. So where do you think, or what do you think the role of education is in what you're setting out to do, and specifically, I suppose, frailty education?
Yeah, thanks, Trevor. It's going to be really important, and we have to equip our people with the tools that they can use to assess and treat the patients that we've been talking about. But they need to be able to do that. We're on the clock, so when we're like us as a panel, we're on the clock. You know, so these things have to happen relatively quickly. We aim to be on scene with a patient for about 20-25 minutes. We'll have them in the back of the ambulance en route to hospital. So we need to identify the assessments and the treatments that will fit with the 4Ms that will be helpful to Kirsten and her colleagues in the hospital. But from an education perspective, identify and deliver those, and deliver them to 2,200 staff who work from 110 locations. So we have an ambulance station in Carrsiveen, we've one in Belmullet, we've one in Carndonagh, and 107 more. How do you deliver that training to a group of people who are working 24/7, 365 on shifts? So very challenging, but
okay, no, thanks for that. Yeah, no, thanks. And Kirsten, I've heard you speak before, and that was a level up yet again from the point of view of delivery and inspiring, which is incredible.
Well, my shoe never fell off before. So.
Can I ask you, I think two questions, and I think one of them is shorter than the other. One, how are the 4Ms, how are the 4Ms actually chosen?
Mm-hmm.
And secondly, I was very struck by Dermot telling us that having a GP for longer than 15 years reduces your mortality, reduces your likelihood of admission, and reduces your ED attendances.
Mm-hmm.
Is there any evidence to support that age-friendly health service systems work?
That's a good question, yeah. So how the 4Ms was chosen really was in conjunction with the Institute of Healthcare Improvement. A group of geriatricians looked at all of the proven evidence-based care models in geriatrics. And then what they found was that amongst those different care models, there was, of course, lots of overlapping features. So they combined the things that were overlapping and in common, and then kind of distilled it down to a much smaller number of discrete features. And then I think there was quite robust debate then about eventually simplifying it down into the 4Ms. So something that nicely captures all of the evidence base, but that's still easy to communicate and scale up. And while we don't necessarily need to kind of show that there's improved outcomes directly linked to the 4Ms, because the 4Ms themselves are already based in evidence, there is now starting to be literature published which shows that implementing 4Ms care is improving outcomes. And just one example of that is there is a nursing home in Boston where they studied the effect of implementing 4Ms care. and they found that they had reductions in falls, increased deprescribing of inappropriate medications, and reduced kind of unmet need in patients with dementia. So definitely the literature is starting to emerge.
And
now.
it's a cascade, isn't it? If you do a medication review and you reduce a medication or omit a medication, you automatically begin to affect mobility and falls. So it's all cascades. Emer Ahern. Oh, well, sorry, one question there. Yeah. So you might just introduce yourself.
Colin Tracy, and a slight, hopefully not off-piece question is, the nutritional needs of the elderly, do they fit under medication? I was just interested, it's important, the food that we're feeding people as we get older. I'm sure it changes, and there's a lot of research in that area.
Yeah, and this came up last week in our expert meeting, actually, when people were saying, actually, are the 4 M's all of the things we should be doing? And of course, if we think really hard about all of the holistic needs of older people, we have to think about their fluids, their nutrition, and a number of other elements of care. So it's not exclusive. The 4 M's is not designed to be exclusive of other fundamental care needs, but we do believe that those 4 key elements are evidence-based, they provide good structure and a framework that will drive better outcomes overall. I think, food and nutrition is almost like a fundamental hierarchy of
And I
needs.
guess as I hear that question, it's a great
Yeah.
question. You heard with what Cathal was saying about the 4 M's and
Yeah.
the 2 E's.
Exactly,
So I think,
yeah.
I love that eyes and ears ad,
Yes.
but I mean, that's something that naturally fitted with what you were doing.
Exactly.
So I think your question around nutrition
Yeah.
fits again like that. And I think that's where
It
people
does.
have to be innovative with the
Yes.
4 M's. But if from an education perspective, I think it's easier to go and grasp that nettle first and then move on with other things. I see Michael and Emer sitting at the back who've been instrumental in what's developing here. Would either of you like to ask a question or make a comment?
I leave Michael finish anyway. No, firstly, I just want to say thank you to the speakers. I actually feel really privileged to have been kind of in the audience today to listen to the 4 of you speak. I thought it was, even though this is my bread and butter every day, I thought they were really inspirational, and thank you very much to all the speakers. I suppose what I kind of, my name is Emer Ahern, I'm the National Clinical Advisor for Older People. Despite that slide, Cathal, showing the clear kind of increase in demand, despite the evidence, that we have what good care looks like, I still every day kind of like, grapple with the fact that why do we still have this gap between knowing the demand and the evidence between implementing kind of like the right care. So it was just in general to the panel and even yourself, Diarmuid, and then Michael will give us the right answer then at the end, I'd say.
Okay, I suppose. Well, I'm Michael Fitzgerald, and I was former Assistant National Director with the HSE for Older People. I was Chief Officer in Cork and Kerry, but I'm gone now and forgotten as well. Or forgotten, but not gone, maybe. But at any rate, I suppose, yeah, remembered by a few. So I suppose first of all, I mean, what a powerful set of presentations, and so heartening to the likes of me, who has been hanging around in dealing with older persons services for so many years, that we're coming to this level of maturity of a thought process, and all of those really good things of people working together. But probably the absolute most important is listening to the person in the middle of it, and the old farmer, he wanting to die outside in the middle of the field, or something bad happening to him, and all the things that are in my head from years of institutionalization of the risks of the cow hitting him and trampling him, and we see it in the paper in the corner, and all of those things comes to my mind. And yet, what does he want to do? He wants to live his life to the end, and he wants to live it with the dignity that he wishes. And I think, kind of when I looked at Cahill's graph, if you don't shed some of our old ways and some of our heavy risks-related issues, and we knowing better for older people how do we think we're going to actually provide services to such a breadth of population? I mean, practically, it's not going to be the case. And practically, with that level of people who live over 85 or over 75, who are our big service users down through the years, if we're not going to be listening very carefully to what they are going to do, and if we're not going to be allowing them to live their lives to the degree that they wish and still try to support their needs, hard and all that might be, I actually don't think you can actually, we'll always be bogged down in all the other things and all of the other things with the EDs and with the trolley numbers and all those, that narrative that is so negative for older people's services. That's just, I don't have any other comment on it, just to say what a fantastic foursome you have been in presenting it to that level and degree. There's nothing new in it that anyone inside here hasn't heard. But when you put it together, how powerful it is. That's all I want to say. Thank you.
I'm conscious of the importance of Tom running his meeting to time, and I really, Michael, your summary of that is really good. I would just like to say a big thank you to Tom for what he put together as a meeting, and having the privilege to chair 4 extraordinary speakers. And I actually think if you walk out of a room, although you have to stay for the next session, but if you walk out of a meeting informed, updated, inspired, and re-energized, you can be a participant in the change that is well evidence-based, well started, and growing. So from me, a sincere thank you to each of the 4 speakers for doing that, re-informing us, re-educating us, engaging us, and inspiring us. It was fantastic. Well done. Thank you all.
No, it went really well. Yeah. Yes, yeah, yeah.
Maybe it was a sign. It's
Yeah,
maybe a good
yeah.
sign. You might go home this evening to tell you, I tripped up right in the middle.
Yes, yeah,
You're like,
yeah.
so did I.
Yeah, yeah, exactly, yeah.
That was great, Kirsten. Fantastic. Really inspiring.
I know, yeah. You can, of course, yeah, certainly. All right, lovely to meet you, Tony. Oh, yeah. Yes.
Yep.
Oh, yeah. I
I'm
do
conscious
remember.
of
I
time.
haven't seen her in years,
That
so,
was
but,
an
yeah, how was
incredible
she?
session, and it's
Good,
amazing.
good.
Emer, when you spoke last year, you really inspired us, and this was fantastic, amazing.
Limerick.
It was wonderful
Yeah,
to
I'm
be
a Cork
part
fan,
of
I
it.
live in Limerick.
So the last session this afternoon, the good news is there is not
we
going
haven't-
to be
yeah,
4
we're a
more
national service, so
presentations.
our
We're just going to get the 4
headquarters is in
people
Tala.
up on the stage, and we're
I'm-
going to have a
I'm
little
live in
bit of a
Limerick, so I'm
chat,
based there.
an
We're
introduction
based
about
everywhere.
themselves and about their work, and an interactive session, because I'm conscious it's been
I'm
a
the
long
clinical
day, and this
director.
is an additional session to the agenda. So I'd like to call on
So the Air Corps are one of
Jared,
our
Norm,
providers, so
Dan,
they-
and
they
Rebecca to join me
provide
on the
a lot of
stage.
aviation support for us. We have a contract with a commercial aviation provider. No, that's the Coast Guard. So Gulf Med is who we're with. Gulf Med Aviation
I
Services.
can hold it, right? Yeah, they're not pockets. No.
Sure. Yeah. That's right. So the Air Corps, the Air Corps are flying.
There's no clip on it. Oh, there is. Maybe I can put it inside somewhere. How's that? That work? Yeah. Okay.
Thanks a million. So
Norm.
the purpose of this session is
long,
really
they're
to talk about
impressive.
innovation in education, training, recruitment, and staffing. And for those interested, we've got 4 people from very different and varied backgrounds, 2 of who have travelled from the US to be with us, and we're very grateful for them to come and join us. And I think perhaps we might just start by asking people to introduce themselves and tell us a bit about their background and their organisation. Jared?
Thank you. Well, I'm Gerard Chimganda. I'm the CEO, Managing Director of Good People. We are initially a recruitment company that could source healthcare professionals internationally now we are in primary health care. We are also in social residential services and home care. So that's who we are. Thank you.
Before you go on, give us a sense of the scale. How many people would you have placed? Or
So since we've started and we've permanent placement, we've placed at least over 100 or more people.
Yep.
In our own services, we would still have another 100, 150.
Okay, great.
Great. Dan Clary, I'm a managing director with Titan Partners. We are an investment bank and strategy consulting firm based in the US, although some operations in Europe as well, about 90 professionals in total. We focus on what we call the global knowledge space, so education spanning from early childhood all the way up through the professional space, and I spend a lot of time at the intersection of education and healthcare, a little bit of what we're going to talk about today. I've been with the firm for 5 years, but prior to that, led M&A and strategy at a publicly traded company in Chicago where I live called Adtalem Global Education, which is the leading provider of graduates to the US healthcare system. They own 2 medical schools, 2 nursing schools, a veterinary school, graduate about 30,000 healthcare professionals out of those schools every year. So really one of the leading players in that space, and we'll talk a little bit more about who those leading education healthcare companies are in this panel, including one here.
Well, full disclosure, Tom knows all about us. Tom is the founder of our organisation and IHEED. IHEED have had a long journey. We upskill our postgraduate medical education and clinical education. So we upskill over 5,000 clinicians annually across 121 countries. We are an Irish-based organisation, and our primary partners are the University of Warwick and the Royal College of Physicians of Ireland. So Diarmuid, our former chair of the last panel, is the president of the Royal College of Physicians of Ireland. And we're growing from strength to strength every year. So delighted to be here today and feel that we had a huge act to follow. So it was an amazing panel, the one previous.
Very much so. Hi, I'm Norm Allgood. I'm the founder, or I was the founder and CEO of Synergist Education. I've been in the education space for 25 years. I founded that company in 2011 and sold it in 2022 and stayed on to run it until 2024. And really what we focused in on was taking career changers in the pre-licensure nursing space, so people that had a degree in some other discipline. And we would work with colleges and universities. We had 10 university partners across the United States that would then take in these students that wanted to do a career change. They would do their 4 to 5 prerequisites, and then they would enter into a direct entry Master's of Science in Nursing program, and in 20 months they would finish with their BSN and their MSN, and then they would sit for their NCLEX. And we had phenomenal results, and over the years we graduated 5,000 nurses. And I knew, I kind of made it when I was sitting there, and I'm feeling very old, getting my cataract surgery about 5 months ago, and the young ladies, the pre-op nurse, and I was like, "Where did you do your schooling?" And she goes, "Oh, it's a small school in Indiana. Now I'm in Arizona where the surgery is taking place." And I said, "Try me, what school?" And she goes, "Oh, it's just this, you probably have never heard of it." And I says, "Again, try me." And she says, "Oh, Marian University." I'm like, "Oh, I built their nursing program." So it has gone full circle where this young lady got her degree. She was in something else like biology, never studied medicine or anything along those lines, or pre-licensure nursing. 20 months later, she finishes, relocates from Indiana to Arizona, and is my pre-op nurse. So it's a fascinating business, it truly is, but I stepped away from it in 24, and now I consult to colleges and universities and help them think through these types of programs without truly being an online program manager behind the scenes. But there's been a lot of requests for me to get back into the field, primarily because after I sold the business, the acquirers have done nothing with it. It's just sitting there. It's still producing nurses, but they're not doing it with other colleges and other universities. It's a difficult business, but sorely needed because we need 2.1 million nurses in America. So,
and just to speak about the barriers there, Norm, what were the barriers you were overcoming? Like, what did your business do that a traditional university didn't do?
Yeah, so this was a stacked on type of degree program. So you would have a traditional nursing program, and they were not serving any type of student that was an adult. Some were doing what was called an accelerated Bachelor's of Science in Nursing program, which was very economically not viable to the student. It cost them a tremendous amount of money because in the US, you get your financial aid, but if you used it for your undergraduate program, you receive no financial aid for your second bachelor's degree. So you may be out $65,000. Where does that money come from? So by developing this DEMSN, I envisioned a program that would get graduate financial aid. And so the student didn't have that financial barrier. So then the next thing that we had to overcome, Tom, was how did you bridge the gap between the hospital and the actual academic institution? Because in the 60s, they were together, and then they separated, and both have different ideas on what a nurse should be. And unfortunately, when that nurse comes into the floor or becoming a floor-ready nurse, it could take 18 months for them to actually be able to be on the floor by themselves. And so really what we started to work on from a workforce solution standpoint is bridging the gap back to the hospital and bridging the back to the institution to say, what can we do to make the curriculum and the learning outcomes more refined so that when the student does come into the hospital, that they don't need that long of a period of time to be floor ready or to be a clinician. So we started to work on that and really hit it up front by embedding learning outcomes from a particular hospital system into the curriculum, which still allowed the student to get their NCLEX preparation and pass that exam, but they were more ready. But also we started to develop a program called Give Me 3 and You'll Be Debt Free. And so the hospital, instead of giving a $30,000 US dollar bonus to a student, or not a student, but somebody to switch from one hospital to the other, we said, what if you redirected some of those dollars, maybe put a few more into it, and said to the student, at the end of your program, once you pass your NCLEX, if you come work for us, we will give you 1/4 of your tuition in the form of a tranche. And if you stay 1 year, at the end of 1 year, you'll get another quarter. At the end of 2 years, you'll get another quarter. And at the end of 3, you could technically be debt-free if you applied all those monies. And so we're bringing the two entities back together, which, started to receive a lot of traction. You just have to be super, super creative and just know that there's a lot of politics on both sides as to why they are separated, and trying to bring those two entities together can be challenging. So
yeah, and just to give a sense, so obviously this challenge is a global challenge in terms of attracting talent to healthcare systems and to retaining that talent and giving them a career path. Just in terms of the ability for that person to gain a salary increment. So you're talking about people.
Typically, the person would, the student we would attract would ideally would have a biology degree, but honestly, it would be poli-sci, it would be English, statistics, and they're working as a barista at Starbucks, making $30,000-$40,000 a year. In the U.S., they would grab this degree and they're making $78,000 to $85,000, and then now they're ready. They're into the groove of it, and about 30% of those students go on to be a family nurse practitioner, and they're making $115,000 to $175,000 a year if they do their postmaster's certificate. So we always, our company really placed the student at the center of the equation, and we wanted to make sure whatever we did had to be economically viable for that student, but also the partner institution, which is the degree granting entity, and the hospital as well. And if you think about it, if you can retain that student for that new nurse for 3 years, you're locked in. You don't have that constant return where you have to fill the void with traveling nurses. That traveling nurse in COVID was making $210,000 a year compared to, the average salary.
Yeah. And does that resonate with you, Rebecca, that story?
It absolutely does, on so many fronts. In terms of the enhancement of the career of the student and the learner, for our nurses, when they complete one of our programs, particularly if it's a master's, they go and they can apply for AP status or a specialist nurse status, and that's an immediate increment on the band within the HSE or in the NHS as well. So that's very, very important. So they have a very clear pathway as to how they can upskill, how they can combine the upskilling with a band remuneration enhancement. For the general practitioners in the United Kingdom, for example, and wider afield, you have the old term gypsy, a GP with a special interest, and that is essentially where they can upskill, do a masters or do one of the RCPI professional diplomas, and they will then get an enhanced specialism in that area. Now, that doesn't necessarily come with an immediate remuneration, but what that does do is if they're going in for a partnership in GP practice, for example, if they're a diabetes specialist, they will be given that extra kind of ability to secure that GP practice partnership much quicker and just enhance their particular area, be it obs and gynae, etc., where they can specialise more in that clinical practice in that area. So that's what resonates very, very specifically with our clinicians.
And do you think the doctors and the nurses differ?
Yes, they do, but I have to say nearly all of our programs are IPE, which is interprofessional education. And as we've talked previously in the other panels, this siloed approach to and this demarcation of you're going to be educated by the nurses and you're going to be educated by the physicians. When they get out in the real world and they're working in a multidisciplinary team and they see how important each cog in the wheel is to the clinical care of that patient, it becomes so obvious that they should be educated together. And that's what we do in nearly all of our programs.
Can you give an example of that?
Well, for example, I will actually use diabetes again, for example. So you have the dietitians, you have the nurses, you have the physicians, you have the podiatrists, and you have the pharmacists, and they are all being educated on the diabetes program. So in the community, obviously prevention is better than cure, and where you're taking a huge amount of onus off the healthcare system by having that person end up in a very chronic position in hospital. If you have the multidisciplinary team working together, you have the pharmacist who can, because they have the ability to prescribe now, and they have the ability to nuance the doses, and you have the doctor who's working very closely with that pharmacist, and then you have the diabetes specialist nurse who is there taking the bloods, bringing that person in all that time. You have the nutritionist and dietitian really monitoring their sugar levels, what they're eating. That is just best case scenario and best practice, and how you make sure that person doesn't end up in acute care, doesn't end up with an amputation, doesn't end up costing the healthcare system an absolute fortune because they weren't monitored correctly in primary care.
Can you just give an example to people of what that educational approach looks like?
Absolutely. So I suppose we partner and we believe in best class, world-class pedagogy, and that's partnering with really, really strong brands. And that's the Royal College of Physicians of Ireland and the University of Warwick. And what we do is we listen to the learner. The learner doesn't have time because they're very, very, very busy clinicians to sit in the car and sit in traffic and drive to university and have one tutorial or one lecture or two a week, or have these study days where they have to take it out of their annual leave. These people have shift work, they have family responsibilities, they're usually the primary income earner, and we need to deliver education at a time where they need to receive it, be that 12 a.m., 2 a.m., 3 a.m. or 12 noon, because we need to deliver what they need and upskill in their own terms. So what we've done is it's entirely online, it's entirely a blended approach where they have one live tutorial a week, and that's very, very discursive. There'll be case-based analysis where they'll be talking about particular medical treatment, etc. And they'll all be in terms of discursive rather than didactic. They're talking about treatments in their areas, whether in diabetes, as your example again, whether GLP-1 or SGLT2 is appropriate in this case, etc., etc. And in that scenario, they're just learning from their peers as much as they're learning from the tutor, and I think that's hugely, hugely important. And also with distance education, if you are not in that kind of social engagement, your likelihood of attrition is really, really high. So that 1 week where they get together, they talk to their peers, they discuss clinical case studies, they get to know each other, they set up their own WhatsApp groups, and they then talk to each other independently of us. And they learn cohesively together, and they've online chats throughout the week that culminate in that live tutorial. That's engaging, But if they miss it because they're on a shift work, they can then access it at their own time, and then they can view the recording. And then we have it on standby. We have a full program support team that, just in terms of technical issues, or if they have a delay in submitting their exam result or their paper, it's very, very important that we are able to adjust flexibly to the clinician, because they have a huge workload already. So understanding their pain points and delivering education when they need it is absolutely what we do.
Very good. And Dan, just to move on, you've obviously been on both sides. You've been an investor in these businesses, and you've run some of these businesses, and you've run them in multiple geographies around the world. Would you like to speak to that a little bit?
Sure. I mean, I think what's interesting about education and healthcare is, there's a lot of similarities between the two sectors, right? They're both crucially important for our global economies. They are, two sectors that, are strongly supported by, nonprofit entities, government funding. Were initially probably slow to digitize, but we're seeing a remarkable amount of innovation today, and I think that's a lot of what we're talking about on the healthcare side, but we're also seeing that on the education front as well. And really from the investor side, I think there's a remarkably similar set of investors who see both sectors as a way to make impact, right? You're looking at a double bottom line of investment. You want to see financial returns, but you also want to see impact on people's lives, whether that's through education or that's through, healthcare outcomes. And so, I think a lot of the innovation layer comes from, around the world, comes from people who are healthcare practitioners and say, how can I train people better based on my own experience? How can I start a company up, as Tom and others did at IHE, to do that, to help educate people in this sector? And I think we've seen some really phenomenal companies grow that way. Some of the leading companies that are out there. I started at a company called Adtalem Global Education, I mentioned before, with 2 medical schools, 2 nursing schools, really kind of one of the leading publicly traded scaled players in pure education. But there's others like Relias, which is backed by Bertelsmann. They're providing all of the sort of workforce training and compliance training for health systems across America. HealthStream is a publicly traded workforce education business, really focused on supporting healthcare practitioners in the hospitals. And some of the other large ones that are out there, Ascend Learning is a sort of pure play healthcare provider that does education in curriculum for universities, but really is trying to extend that pathway into the workforce, thinking about how they can use education to change patient outcomes over the long term, exactly the way that that Norm and Rebecca talked about.
And Dan, you've worked in this sector for 20-something years, right? And you've studied thousands of companies, and you've seen hundreds of them involved in due diligence on them. What has the commonality been of the successful ones? What would you say are the top 5 attributes of the ones that nailed it?
Well, I think that outcomes focus is really the number one across all of them, right? I think if companies that are focused on learning outcomes or patient outcomes,
quality,
everything else comes in place, right? I think you can look at, in the software world, we always talk about retention, right? What is your revenue retention of former customers? That's really a backward-looking metric. If you think about the future, how do you know what the revenue retention is going to look like? Because you're providing a good product, right? The people are coming, they're going through your education, and they're getting placed into the right clinical clerkships, the right hospital programs. They're getting the learning outcomes that they really hope for. And I think that goes across, upskilling, right? If there's continuing education, if we think about kind of the conferences and events that doctors have gone to for many years, it's a way to get connected to the latest research that you can use and utilize in your practice. And I think that's a really important element in this sector. The reason that a lot of investors actually get excited about healthcare education as opposed to many others is that there is a willingness to pay for good products, right? I think some other sectors where you have continuing education, it's a little bit more of a check the box exercise, right? You need to get that in order to maintain your license. And in healthcare, most professionals see this as something that's really going to improve their success with their career, but also improve their ability to relate to and deliver great outcomes for their patients.
So quality is one of the big metrics. Are there other things you'd see in those organizations
I think passionate founders is always a key. For growing companies is people like I mentioned, many coming from that practitioner landscape and understanding the metrics. Ability to scale is certainly, especially if you're a smaller business, what is the ability to tap into the market? And I think one of the interesting things about people selling to medical schools is that there are not that many medical schools around the country, around the world even. So how do you start moving into nursing or allied health or other areas of healthcare where there's a lot of expansion potential? And then certainly, the thing that values every company is their revenue and profitability and growth.
Sure. No, thanks, Amelia. And obviously, George, to come to you. I mean, recruitment, I suppose the connection between recruitment and education is critical.
It's very critical, especially in compliance in Ireland, and really matching the international qualification to still be, tick the boxes of what's required in Ireland. So that link between training and education and bridging that gap is going to be very key.
Yeah. And can you give an example now of, say, somebody you might place from Zimbabwe or Zambia, you mentioned to me, Philippines?
Yeah. So what we've tried to do then is to ensure that they are aware of the, required courses in advance.
Yep.
So if it means preparing them to start, that's why platforms such as AHEED, I think, are going to be key. We just got a doctor there from Malaysia, and she actually told me she did one of your courses there, and it was easy for her to then come into Ireland and be able to work as a GP. The next stage is then how you get those professionals to continue their professional development.
Yeah.
And so whilst they work and are busy and, because they can't take time off to actually do that, they've come to work, they're on a work permit, they need to work certain hours. So having such flexible models is going to work and help that bridge that gap.
Yeah, and I mean, if you look at those career paths from the global south to here, or from the east to here, and then on to the US and Canada, we see it all the time on the medical side, don't we, Rebecca?
Yeah, huge amount of global
Huge.
mobility
Yeah.
and real appetite.
Yeah, and obviously education is part of that. Can you give an example of the kind of postgraduate qualifications, that kind of career paths in the non-clinical areas?
In the non-clinical areas, obviously, one of our kind of programs is hugely popular is the healthcare leadership program. And that would be obviously all around, you have the clinician and they're extremely competent in that particular area of their specialty. But so many doctors and clinicians globally are naturally seen as leaders, but they're never taught. There's no accountancy course in your undergraduate medicine qualification, and there's no PR, and there's no just instruction on how to do the day-to-day building of an organization, which is an entirely different world to the building of a GP practice, for example. Or if you're a nurse and you're there, all of a sudden you've climbed up to director of nursing. Nobody has taught you how to look at a budget, how to manage that budget, and you have never had a grounding in that. So, and they are natural leaders. Clinicians are just born leaders. So to give them the tools and the confidence to just tick those boxes in their education to, I suppose, just solidify what is naturally there and give them the confidence to just grow that further. And we see an awful lot of international mobility, particularly in the Gulf, when they do the leadership program. They move on based on the University of Warwick, because it's a Russell Group qualification, and it's known globally. So they may have originated from Pakistan, for example. They go to the Gulf, then they study the leadership program, and then they go mobily, usually towards the West after they've completed the program. So they see it as a tiered approach to climbing and just gathering that information and growing their career.
Yeah, I mean, I suppose the big career moves are into either clinical education, into clinical research, into leadership, or one or two other areas. Norm, just one of the things you did, which I thought was fascinating, was you basically took PhDs online.
Yes, yeah, it was doctoral level programs, and we created the biggest problem with a PhD program is 60% of the people that enter the program do their coursework, they don't graduate. So I developed a doctoral level program that begins day one with your dissertation. And so you begin day one work on your dissertation, and within 3 years you finish with your doctoral level degree. And it was done in an EDD format, and we took a lot of PhD students that they were all but dissertation and brought them into the program. But the other thing we did with it was it helped us prepare faculty in the nursing programs that could teach at a graduate level, because with accreditation, as long as they are enrolled in an EDD program, they are considered doctoral level faculty in a nursing program. And it's also a stickiness factor to keep the faculty. So if you think about one of the biggest hurdles overcome with nursing education is how do you have doctorally prepared nurses and retain them? So you say, look, you already have your graduate degree, you're already teaching at a bachelor's level, we want to teach you, have you teach at a master's level. To do that, you need your doctoral level degree. We're gonna go ahead and we're launching this program at Gwynedd Mercy University, and you're going to be able to go and do your doctorate for free. And the other students, will come into the program from all sorts of other disciplines, but you are now going to be a doctorally prepared faculty member as long as you stay with us for 3 years. And that really is a tremendous stickiness factor. And it grew like gangbusters for us. There was only about 13 such type programs at the time that we did it in the United States, and our completion of it was tremendous compared to a PhD program. It really served a tremendous niche. So
Thanks. And Dan, did you see many examples of that?
Yeah, quite a bit actually. And I mean, I think exactly that laddering effect that Norm was describing before of going from, originally the RN programs. When I first joined at Talem, then DeVry, we had just acquired Chamberlain College of Nursing, the nonprofit, small regional nursing school owned by a hospital in St. Louis, one campus. And, I think the view was we wanted to try to expand the number of campuses so we could offer more RN programs, associate level degree programs for nurses to enter the space. And it was over the time that we added that completer degree to get people to the bachelor's degree, to get people to the master's degree, to get people to the doctor of nursing practice, and putting that all online. It's all of the retention tools of partnering with health systems to do that. And I think there was definitely, finding faculty for the doctoral programs was a challenge,
right.
but it was about increasing access, number one, right? There were not enough, there still are nowhere near enough nurses in the country, but increasing access for people to be able to go from diverse backgrounds, to be able to go to these, to nursing school, to afford nursing school, and to be able to move up because your employer was now paying for that. The employer saw it as a retention tool, and we partnered with, to the point where about 50% of our tuition revenue was being paid directly by employers. So they were saying, you're gonna come in here maybe as a licensed nurse, but we're gonna pay for you for 2 or 3 successive degrees from here on out, until the point where you become, a doctor of nursing practice, and then maybe as your career, you get to towards the end of your career, maybe you become a department leader, and you do start to get some of the leadership experience that Rebecca described, and some of the accounting experience and compliance experience and all of those things that are really important to ensuring that the health system thrives.
Yeah, and we've heard that from Northwell today, and we've heard it from other organizations, how critical it is. And in the previous panel, it was all about the quality, wasn't it?
Yeah.
So just in terms of recruiting faculty, just give a sense how you'd go about that, or you've gone about it, Dan, or you've gone about it, Norm?
The best way truly is to find the faculty from the hospitals that you're serving, right? So, we would have 2 full-time faculty members assigned to the direct entry Masters of Science in Nursing, and the rest were adjunct. And the key to that is you're making sure that the adjunct faculty are making the same rate that they would if they picked up a shift in the hospital. And as long as you can have that parity, and then also really show them, this is a possible career path for you after you leave practice to teach, and that really helps a tremendous amount. It's like finding in those business programs those working professionals that can bring real world experience into the classroom. these nurses are bringing real world experience into the classroom as well for these nursing programs. And then you layer on top of that, if you're able to do a doctoral level program for them, again, that stickiness factor is very powerful. So.
Yeah. And then just in terms of innovation, sorry, Rebecca, did you want to say something on that?
We approached the faculty piece very, very different.
Yep.
So we started when we have a very unique model. We're not exactly what you would call an OPM, and an OPM is an online program management company where you'd create the content for a university or an educational institute. We do the cradle to the grave, essentially the lead or inquiry right through to alumni process in IHEED, and work in partnership with the University of Warwick or Royal College of Physicians in order to create these programs. When we're creating them, we totally storyboard. We use the instructional designers and we go after the best SMEs on the planet, whether they're Johns Hopkins, whether they're Cambridge, Oxford, all of the best. And then we ask them, because they get so interested and so involved in the storyboarding and creating the program, and they feel ownership of that, then very often they ask to be part of the lecturing group, or we ask them. And, you know, a lot of them don't, it's not a money-driven thing for them whatsoever. It's because education is their passion. So they start off as an SME and then go on to be part of the tutoring group. And so it's not necessarily from the accrediting body. Those academics are from all over the planet. And also another area, because we are so global, and that whole West knows best thing is not going to cut it. And so when we are delivering in Malaysia, we always recruit Malaysian local academics, and we then mix them with the international faculty that the students will be expecting as well. Because what medicines and what insurance policies, all of that at a local environment is so nuanced throughout the globe. So whether we're delivering in the Gulf, we're delivering in Africa, Europe, North America, Canada, or Australia, Malaysia, we hire local faculty as well to nuance that content and make sure that it's very, very realistic for the clinicians that we're talking to.
Very good.
Yeah.
And just to, sorry, do you want to say something?
No, I was just going to say, I mean, I think the important element here too is particularly in the degree programs, but even in some elements of kind of further education and continuing upskilling is there's the faculty that are teaching in the hospital, I mean, in the classroom, but there's also sort of the practical experiences that are required, right? And I think that, you know, trying to partner with health systems, especially since all of these schools, as Norm mentioned, since the 60s and certainly all these online schools don't have their own captive hospital, right? So they're partnering with third-party health systems to try to find practical experiences, clinical clerkships, and eventually lead people into residencies post-graduation at the medical schools. And so, you know, finding practitioners that can give that practical experience, managing the students through those rotations is challenging. And I think there's a lot of innovation around that with, you know, everything from sort of virtual reality that came out during the pandemic to some, you know, new techniques that that are emerging just to help that happen at scale, particularly for these students that are doing things online.
Real quick, Tom, just two things. You touched on the curriculum development, but I think the other barrier that we haven't spoke about is the boards of nursing in all of the states. Every board of nursing believes they invented nursing, and each one of them has their own nuances. So one of the things we did with Synergis is we put an entire regulatory team in place, and we would help our partner institutions navigate the regulatory framework, and they would be the ones that would be submitting the applications, but the heavy work on the business plans and all of the other things along those lines, we would help them with tremendously. And then the other piece of it is the curriculum development piece, and that would help with the hearts and minds of the faculty, because going in and just saying this is a white labeled program, you're going to do it, even though 80% of what you're teaching across the board, regardless of the institution, you're teaching towards the NCLEX, you still needed to win the hearts and minds of the faculty. And so to your point about subject matter experts, that is who the subject matter experts are, but we would put alongside them instructional designers, media specialists, instructional strategists, and then they would navigate that whole curriculum development process all the way through, where 40% of the curriculum, the didactic curriculum, is online. Then you have your simulation, then you have your skills lab, and you get into a little bit more of a repeatable process of best practices. And that really helped us achieve the high NCLEX pass rates, which then helps you get more clinicals, which helps you expand those programs even more from a regulatory standpoint. So there's a lot of moving pieces to make these programs go. But at every turn, you feel sometimes like the nursing boards, the hospitals, and even nursing schools stay awake at night trying to figure out how they can throw roadblocks in your way so that you can't produce nurses. It's very, very frustrating. And you know, we entered the pandemic needing 1.8 million nurses. We exited it needing 2.1 million, and we haven't put a dent in it.
Yeah, I see a few smiles in the audience of people who obviously feel your pain. Yeah. George, have you some takeaways for the audience in terms of your thoughts?
Well, just in line with the whole regulatory thing, I think we brought the first nurse from Sri Lanka to register with the NMBI. They had no history. And they didn't even know about the schools and the process. She was already in Ireland working for us as a healthcare assistant. It took almost 7 months. And so you then see just the need of bridging that regulatory gap, but also creating a simple step process that can be understood by both sides. Since then, there's been, I think, about 15, 16 nurses that have come. Some then came to do a bridge program or with Tralee, which is now Munster University. And we brought 13 of them. And so just that gap, and for Ireland to actually prepare for more people to come, because the shortage is real, it's very important to have these pipelines of training. And if you can do that from at source, you then have prepared people that then come and get into the field, especially now with the UK stopping all healthcare visas. That's an opportunity for Ireland.
Yeah, I totally agree with you. I mean, I think if you look at the pipeline, if a healthcare organization can control their pipeline, a bit like the supermarkets, Tesco's, contracted farmers for their beef for the next 10 years. If you can form those long-term strategic partnerships with the healthcare organizations and allow, you know, it's easier to put all those steps in place in a structured way. Dan, have you some takeaways? I'm conscious that a small group of people have been very loyal and stuck with us.
Thank
but
you.
I want to put you out of your misery.
No, I mean, I think what's interesting about that last point is really, you know, one of the more innovative transactions in the space took place a couple of years ago, and I think we haven't fully seen it play out yet, but when HCA acquired a nursing school, Galen College of Nursing in the US. So I think we will see more of this, and we've certainly seen a number of sort of large health systems think about how do we directly kind of vertically integrate that, you know, talent pipeline, right? We talked a little bit about getting the graduates ready to be, you know, prepared for contributing on day one. And I think, you know, one of the things when people are graduating from a nursing program, you're learning all of your, you know, didactic expertise coming out of that first, you know, licensure program, but you're probably not learning how to use the Epic or Cerner, the electronic medical record system of the hospital you're going to go work at. If you knew which hospital you're going to work at when you graduate, you knew what systems they were going to use, you knew everything else, and you were part of that system, you were going to do your clinical rotations within that hospital, it makes it a much more, you know, clear pathway, and it starts to look more like the training models that worked, you know, a century ago versus today. But these, you know, large giant health systems like HCA, they need tens of thousands of nurses every year in order to kind of meet their demands. And so, you know, building that vertically integrated pathway from education to staffing to delivery, I think is going to be a really important, you know, aspect in the future.
Yeah, and I think if you look, a good example just at a practical level before we go was, Rebecca, is to talk about the family medicine program in Malaysia. You want to speak about that briefly?
Yeah, we're very, very proud of the Mint FM program, and it's just a testament to, I suppose, Irish bodies working so closely together as well. So it's a tripartite agreement and arrangement between the Irish College of General Practitioners, RCSI, UCD and IHED, and we deliver a blended approach to upskilling general practitioners in Malaysia to become family medicine specialists. So it's a 4-year specialist training program. And we have over 440 students on that program now. and it's growing year on year. It's recognised by the MOH. They get their clinical registered as a specialist, a family physician after they finish that program, and we're scaling, and which is in dire need in Malaysia. So we're hitting that scaling point and growing rapidly, and growing our centres throughout Malaysia as well. And it's very exciting to see it grow and see so many of the students begin to excel and climb that career ladder and tick those boxes through a blended approach of online education and obviously their clinical education, and then going into the centres for their learning as well. So it's a really, really nice approach to scaling.
Yeah, and that was funded fully by the government in Malaysia
entirely.
To solve a problem they have in the
Entirely.
country.
Yeah,
And we're beginning to see a trickle of some of those family doctors coming to Ireland now,
absolutely.
as is a natural outcome.
Yeah.
Any takeaways, Norm? Final words?
You know, I think a lot of it was already said. I think the biggest thing is we really need an entrepreneurial spirit, both at the hospital and at the education academic level, to be able to solve this equation. Because if you think about it, most of us, the second person to touch us when we came into the world was a nurse, and probably the last person that will do that will be a nurse, and and many times in between, and we're not getting any younger, and we all saw the graphs, and we need nurses. We truly do, and that is my passion, and that's where I have focused for so many years. And because not only are they nurses, they could be so much more after that. Unless we really try to get rid of these bottlenecks and these, faux obstacles that are throwing into the way, we're always going to have this false supply and demand that could really be mitigated with the right tools.
Thanks. Rebecca, have you any final thoughts?
I suppose for me, education shouldn't be seen as a one-off cost by governments or employers. It has to be an infrastructure. Education is an infrastructure and has to be embraced. And I think a co-funded model, particularly at postgraduate level, where it is the employer, the government, and the individual, the clinician, co-funding their education, so there's skin in the game from all bodies, will be a game changer. So it's a mindset shift towards funding the continuous education of our clinicians.
Dan?
Yeah, no, I agree. The continuous education is crucial, and having innovative digital tools that help to support that, help to support clinical decision support, right, and continuing education when you're. I mean, I think we haven't touched upon things like AI and all of the adaptations we're seeing in education and healthcare, but I think these are tools that will help us to have the most recent and most relevant education and information at our fingertips, so we can use that to ultimately provide better patient care. And I think that's what's probably the most exciting about all of these things we're talking about today.
Yeah, I think those new models, and a shout out to Gideon at the back there, who's with Global Health Education Group out of Imperial College, who's doing virtual clinical placements and remote teaching and live interactive classes, which is an exciting development as well. Jared, your final words for us?
Well, I think that partnership, as everyone has said, is very key, especially to meet the personal ambitions of somebody. We're going to keep them working with a hospital or whatever. They need to know that they will get that certificate that allows them to move to the next stage. So it's key.
Great. Well, listen, on behalf of everybody, I'd like to thank you. And more importantly, I'd like to thank all of you who've stuck with us. I know it hasn't been easy. I know if you want to have an individual question with any of the individuals, they'd be delighted to talk to you afterwards. So thanks, everybody, and safe home.
Thanks, guys.